Diagnostic excellence to improve patient safety. In events with heroes
Okay,
or
great.
with
Okay,
different time.
I can do these.
Okay.
Works. All right, thank you so much for having me today. All right, I have no disclosures. And so today, the two major goals are to describe how to apply the Safer DX instrument to identify if there was a missed opportunity for diagnostic excellence, and then utilize the DEAR taxonomy, which is a method to identify failure points across the diagnostic process. We just passed World Safety Day. The WHO this year is actually focusing, in fact, on improving diagnosis for patient safety. So back in 1999, actually before I was even a medical school graduate, the Institute of Medicine published To Err is Human, which you may have heard about, which really brought national attention to medical errors and their consequences. I remember my cousin actually reaching out, flabbergasted the degree of errors that were actually impacting patients, and they estimated the deaths per year from medical error to be close to 100,000. And so the agenda was to reduce medical errors and improve patient safety really through a safer system redesign. And so the early momentum really focused on harm related to medication errors, given how frequent they are, hospital-acquired infections, and through standardizing processes. So this is where the concept of a timeout, for example, occurred to avoid amputating the wrong knee or leg, and then bundles and checklists, particularly to improve or to decrease central line infections. And diagnostic at this point in time was mentioned, but was not a major focus. And so then in 2017, the National Academy of Medicine, which was really renamed from the Institute of Medicine, recognized that we did have a need to improve the diagnostic process in healthcare, and so published this, and the quote from there is that the best estimates indicate that all of us will likely experience a meaningful diagnostic error in our lifetime, sometimes with devastating consequences, which is sobering. An additional way of looking at this is from the Society to Improve the Diagnosis of Medicine. As you read articles about diagnostic errors and excellence and cognitive bias, they'll quote certain numbers. And so, for example, 1 in 3 malpractice cases that result in death or permanent disability are from an inaccurate or delayed diagnosis. 12 million diagnostic errors affect, or 12 million Americans are impacted by diagnostic errors a year, which is the highest cause of harm. And then roughly 80,000 deaths in the US per year can be attributed to diagnostic error, and that's limited by the actual capacity to measure. And so diagnostic errors NAM call the next frontier for patient safety. And we focus a lot of our attention on treatment errors, but the reality is that's just the tip of the iceberg. And if you think about it, that the two major products of clinical decision-making are diagnosis and treatment plans. And if you get the diagnosis correct, your treatment plan will also likely be correct too. And the consequence being that if it's wrong, your treatment plan very well may also be incorrect. And so NAM defined diagnostic errors as the failure to establish an accurate and timely explanation of the patient's health problems, as well as communicate that explanation to the patient. And again, the limitation here is we have limited reliable measures in how to actually identify and measure diagnostic errors. And so we all participate in the diagnostic on any given day as we're practicing medicine, and the dimensions include our initial patient-provider encounter, and what we think is going on is influenced by the tests that we choose to perform and how we interpret them, whether or not we decide to get subspecialty consults and referrals, and then what happens as we do follow-up and tracking of diagnostic information, because the diagnostic process is almost never one moment in time. It evolves over a period of hours, days, weeks, months, years. And at any one of these points, if there's a process breakdown, you can see a diagnostic error occur. And in this, in the pie chart on the right, there is our data from 100 patients. These are adult patients. But what the authors did was broke it down into different causes of factors causing diagnostic errors. And you can see that the majority were caused by a combination of both systems and cognitive factors. But if you combine both systems, cognitive and cognitive alone, that attributes a large proportion of factors leading to diagnostic errors. And so if we think about the interplay of diagnostic failure and outcomes, there's diagnostic process errors, which is we sent the wrong lab on the wrong patient. We sent a hemoglobin, we failed to follow up on it. We didn't do an important part of the physical exam, including diagnosis errors, which we either had a delayed diagnosis, we missed it and we failed to identify they were sick, or we just had the complete wrong diagnosis at all. And then those may or may not contribute both or in isolation to adverse outcomes. And those adverse outcomes can impact not only the individual patient, but our healthcare system in terms of cost and waste and either malpractice claims or ordering unnecessary diagnostic tests, for example. And so I don't know if anyone has heard of the case of Rory Staunton from New York. He was at the time 12 years old, had no significant past medical history, and he cut his arm when he was playing baseball, didn't really think anything of it. And the next day started to develop vomiting, fever to 104 and leg pain. So they brought him into his pediatrician, said, you probably have a gastroenteritis, you're dehydrated, let's go to the emergency room. He went into the emergency room in a large academic center, and he was there for 2 hours. They rehydrated him, gave a diagnosis of gastroenteritis. His skin actually was identified to be mottled both at the pediatrician's office and in the ED. He was tachycardic, he was tachypnic, and they sent a CBC, but the CBC actually resulted after he went home. And the white count of 14.7, I'm not sure. I mean, it's been a hot second since I practiced general pediatrics in the ER, but I'm not sure in the ER if that would have flagged me. But 54% bands probably would alarm most of us. But it resulted after he's discharged home. So no one knew about it. The ED physicians didn't know about it. The pediatrician didn't know about it. And over the course of the night, he got worse. And so mom called the pediatrician repeatedly the next day. He's getting worse. He's getting worse. Just try to rehydrate him. He's like, he can't keep anything down. His fever can't come down at all with Tylenol and Motrin. So they actually brought him back to the ER that night, admitted him to the ICU immediately, and he died of group A strep sepsis 3 days later. So truly, this was a preventable cause of death in an otherwise healthy child. And so you can see there the interplay of the diagnostic process error, that a lab was drawn and we didn't know the result by the time the patient went home, and there was no process to follow up on pending labs. There was just a diagnostic error where the presumed diagnosis was a gastroenteritis in a healthy kid with vomiting and abdominal pain. And I think the thought there was, well, what about the leg pain? And apparently his leg pain was so severe that at one point he couldn't even walk. And this was actually in the context at the time that the Greater New York Hospital Association was in the midst of a Stop Sepsis campaign. And so there was ongoing work with emergency departments to think through timely recognition of sepsis as well as then management of sepsis. And so if we think about the concept of cognitive bias and clinical reasoning, we think about clinical reasoning, there's two modes of processing information. There's that intuitive, reflexic, that quick thinking, okay, you're 12 years old, you have abdominal pain, you probably have a gastroenteritis, as well as the analytic, wait, hold on a second, this leg pain, is that weird? Do I need to actually think through what else might be going on? And so there's a great book called Thinking Fast and Slow that's not long and not hard to read. That's quite fascinating if you're interested in this topic. But we all use this concept of heuristics, which are mental shortcuts that help us avoid analysis paralysis. If you have an adult coming into the ED with crushing chest pain that radiates down their arm, and you don't want to be thinking through the differential diagnosis of 8 million things before thinking about a myocardial infarction. And so really, cognitive bias is sort of when we don't process the full range of information presented, and there's more than 100 that have been described. And back when I was, doing the clerkship and the sub-I and the residency program, we would think through, okay, well, what was the cognitive bias that was experienced here? And I would end up swimming in the so many different forms that are out there. But the consequence is that you have a diagnostic failure rate that's at least 10 to 15%. Again, and most are going to have some form of a cognitive component, with a consequence estimated to be that there's 10 deaths per year per any individual hospital in the United States. And so that's a big deal. These are preventable deaths. Rory's parents started the Roy Staunton Foundation to really focus on ways to end sepsis as a result. And so if you think about thinking fast and thinking slow, there's this thing called the dual process theory, and part of the diagnostic process where you have a patient, they come in with a typical, 6-year-old with sore throat, probably have group A strep, for example. And you look for the things that are going to actually then sort up or down that process. And so to some degree, you can rely on the pattern recognition. I've seen this pattern a million times. This is probably what it is. If you've never seen a 6-year-old with strep throat, you might be like, all right, I have to go back to my, as your 3rd-year medical student, like, all right, well, what's the differential diagnosis? I remember that, like, being overwhelmed with, how do I actually even create one of those? And a lot of it is experiential. And so historically, the FAST process has been blamed for diagnostic failure, but in fact, they both can. And the point is to really think through this thinking fast and thinking slow, and that T is a toggle, because depending on what you're seeing and how the patient is evolving, you actually want to toggle between the two of them. And this is something that comes really with time and experience. And so these are just some example of the many cognitive biases that are out there. I talked a little about heuristic failure. There's cognitive biases attributed to attribution, for example, which is like, I really don't like that patient, or this is a really challenging family, or they're a frequent flyer in the ED, they're coming in again, they're just looking for pain meds, or cognitive bias related to errors of context. For example, I've just seen 10 kids with a gastroenteritis, so of course, likely the next kid coming in with vomiting abdominal pain is going to be a gastroenteritis. And so there's this concept then of cognitive debiasing, when you actually can then recognize that the cognitive biases exist, you're at risk for them, and how do you basically mitigate them over the course of the diagnostic process? And if you don't, then you have debiasing failure and a distortion of clinical reasoning, and you're prone to diagnostic error. And there's a number of different opportunities that put you at high risk for this, which include frequent handoffs, for example. Was the diagnosis suggested to me by someone else? If you have a kid coming up from the emergency room with a diagnosis of appendicitis, you actually want to think through, do I think this patient has a diagnosis of appendicitis, as opposed to just accepting it, which many of us do. When I'm on call, we're getting patients transferred in from hospitals across the Philadelphia area where a diagnosis has already been made. And I have to sometimes stop myself, be like, actually, this might not be the diagnosis. I trust this person. I have a tremendous amount of respect for this person that I know that's calling me, but I actually need to stop and think through what I think is going on. And so there's opportunities to recognize that you're at risk. And this happens over the course of a career. You learn how to sort of do this. The challenge is that to actually operationalize how to do it at a systems level is very hard. And so it's been understudied. And so the concept is there, but the reality of how to actually achieve it is easier said than done. And so again, if we think through the overall diagnostic process, we have a patient that engages with the healthcare system, and it goes around in a circle as we're getting information, we're learning more, we're thinking through our differential diagnosis. We then need to communicate that to the patient. Loss to follow-up labs are actually a common cause of diagnostic error, which leads to treatment. And so then that outcome can be accurate and timely diagnoses, but maybe diagnostic errors or near misses. The near misses are my favorite in when it comes to safety events, because you can have a safety event that reaches the patient and you then investigate what went wrong, how do we fix our system. But the near misses are the ones that you catch before it reaches the patient. The last barrier perhaps caught it. Well, great. What can I then learn about my system to prevent it from happening and actually reaching the patient again, if that was just by chance, for example. And so again, that influences patient outcomes and system outcomes. And so what we really look to do in this concept of diagnostic excellence is then learn from our diagnostic errors, our near misses, as well as our accurate and timely diagnoses. Because then that feeds back into improving the diagnostic process in the system as a whole. Because we as individuals function in an incredibly complex system. And so you never hold an individual accountable, for example, for systems failures. You need to fix the system. That was really where the Institute of Medicine came from, is we have to create systems that support us as individuals. And so the DEAR taxonomy was actually a 3-year review of cases where practitioners reviewed cases and learned from them. And what they did was they categorized the steps in the diagnostic process, what they call the anatomic localization, and then identified the failure points or the lesions themselves. And so by classifying events and then mapping the failure points across the diagnostic process, they were able to identify where there are areas in that when there are breakdowns to learn and improve from them. And so I'll walk through basically that here. I'm not going to read all of them. You should be able to read them. But so the diagnostic process step for access and presentation is, does the patient actually have access or delay in seeking, or are they actually denied care? And then moving on to history, do we obtain an accurate history? Do we actually act on it? Do we misinterpret it? From the physical exam perspective, do we perform it correctly? Do we do it inaccurately, or do we miss actually a physical exam finding, that mottled skin, for example? Or do we do suboptimal weighing? I see this a fair amount when I do our reviews. Or do we then not actually act on abnormal findings? You can see here when it comes to testing, be it laboratory, radiology, that includes pathology, these are a lot of failure points. And that includes actually, did you get the right test? Did it get performed in a delayed fashion? Did you order the wrong one? Did you order it in the wrong way, so you didn't actually get what you were looking for? Was it processed incorrectly? Did you misinterpret it? And then did you act on it? I will never forget my intern year. I had a patient who was adolescent, and I knew I was going to be a neonatologist. And so any of the pseudo-adolescent patients, I shifted towards my friends. But she had come in a few months earlier for a routine workup, and we had sent routine labs, which included a CBC. And as resident, this is before an electronic health record, we would keep index cards of like patients that we saw, because we couldn't even actually guarantee that we would get their chart back. And she came back because she wasn't feeling well. She was really tired. She was having a hard time staying awake in school. And so we saw her and we looked through her old lab results, and her hemoglobin that had been done at the time was 7 months ago. And we had completely missed the follow-up of that. And now she's been anemic for another number of months, and it was just completely missed. She was okay. I felt terrible though. And so that's an example of a failure of diagnostic test follow-up that's fairly common. Hypothesis generating, right? Do we make the correct diagnosis? Do we suboptimally weigh or prioritize, as I see a lot? Or the lower weight given to a, too much weight given to a lower, the zebras. And referral consultation, do you get the right consults? And then monitoring and follow-up again. For example, inact or missed physiologic monitoring, you may see this when a baby has been born with hypoxemic encephalopathy and there's been fetal distress for a while that was missed. And then failure delay to then follow up is common. So I'll walk through a case. This isn't a real case, partly because in Philadelphia, the malpractice environment is very intense. And so if we talk about true cases, we do that under what we call M-Care protection, which allows those discussions to be not discoverable, as well as then only really intended to learn from them and to help our system. And so when we present cases, we, for example, get full legal review, and we do so in a protected environment. So this case is made up for that reason, but it's honestly taken from a number of different cases that I've seen over the course of my career. And a 11-day-old infant born at 28 weeks, preterm labor, birth weight of 750 grams, a little small, mild respiratory distress syndrome on CPAP, started feeds with breast milk and having intermittent residuals. Common. When I was a resident, we used to check residuals all the time, and that would determine whether or not you advanced feeds. Over time, that has sort of fallen away, but it's still so common to have stuff left in the stomach in a premature baby. And took a few days to stool for the first time, needed to give a glycerin. Very classic. And then 3 days ago, developed bilious emesis ×1. Baby's now on full feeds, but has a history of a pokey belly. Get an AP film, it's unremarkable. Hold feeds, watch the belly, everything looks okay, feed again. Baby's now stooling regularly. And so then yesterday had another episode of bilious emesis. Another film is okay. The exam is CPAP belly. We're blowing air into the belly, so it's a little full. And so we say, okay, I'm going to get an ultrasound to make sure that everything is okay in terms of worried about malrotation of volvulus. And there's a normal relationship of the superior mesenteric artery to the vein, which is reassuring. Again, we'll hold beads. And then this morning, more bilious emesis, progressive abdominal distension, a paucity of gas on film. Maybe there's some free air. There's a metabolic acidosis. So it's okay. Let's call the surgeon. The baby probably has NEC. They're going to need to go in and look. And the baby actually at laparotomy has malrotation with volvulus, which had been thought of, but reassured by the negative ultrasound finding, and the entire small bowel is necrotic. And so I've seen versions of this case, in the last year or 2 or 3. As a resident, actually, there was a case where a baby had, bilious output. We actually got an upper GI, which was read as duodenal atresia. And in fact, he didn't have duodenal atresia. He had malrotation with volvulus, lost everything, and ended up with a small bowel transplant. And so to me, malrotation with volvulus is, of course, a not miss, but the consequences are so devastating. And here's a publication from the late 1980s. I love to find publications that have great titles. So The Deadly Vomit. And in this case, they had reviewed 137 cases and identified a 19% mortality in all age groups that was invariably related to the delay in presentation or diagnosis. And that's because clinical signs were not apparent in most cases until gut infarction has occurred. And I've actually seen cases where, a gas is obtained to look for acid base, and we're reassured by, a normal acid base finding where it's not necessarily apparent. And so I live in fear of missing of volvulus. As a brief review of the anatomy itself, there's normal rotation and fixation that creates this broad-based mesentery between the 4th and 12th weeks of gestation, so that you end up with the ligament of Treitz in your right upper quadrant and then the cecum in your right lower quadrant. The cecum actually descends over the course of gestation. And there's a spectrum of rotational anomalies, which include, for example, gastroschisis and omphalocele. Those patients are in non-rotation, but 40% of cases are isolated. And the true incidence is unknown because in many cases is asymptomatic and may be found at autopsy as an adult or present later. But it's as high as 1 in 5,000 or 500 live births. And then you see volvulus in 1 in 2,500. The vast majority present in the first year, and most before 2 months of age. And diagnostically, an abdominal radiograph is neither sensitive nor specific. I did just have a case recently that I caught, and the stomach was just too big. And it was a baby again that was having bilious emesis. And I think that's where, when we discuss it, it's like, well, bilious residuals can be very common. Neonates, particularly preemies, will reflux bile back into their stomach, but bilious emesis is a bit different. And so certainly there are signs that you can look for, but diagnostically, a contrast enema is also suboptimal in sensitivity and specificity. And that's because the cecum position may be normal, but it's also variable even in normal rotation. The upper GI is considered the gold standard, and what you look to see is for the duodenal jejunal junction to fail to cross the midline. So this, let's see if, yeah, use the mouse. Here we go. So here is the C loop of the duodenum, and this third portion of the duodenum is not crossing the midline. What you want it to actually see is to come across to pass the spine. And so this is diagnostic for a malrotation. And then what they look for on past that is this swirling sign. Sensitivity is not absolutely perfect, and it's actually lower for volvulus than it is for malrotation. Ultrasonography has certainly come into play as a very fast and non-invasive modality that has gained traction. There's tons, right, of point-of-care ultrasound programs. And what that does is it determines the orientation of the mesenteric vessels. And there are signs that they can look for to actually also see volvulus, which can be quite good, but it's operator dependent. And so the institutions that have published success with this have very robust training programs, not only for their ultrasound technicians, but also for their radiologists, because it is fairly easy to either misinterpret, or the orientation of the mesenteric vessels may not actually tell you. And so the consequence of the delayed diagnosis is, at its worst, complete and total ischemic necrosis of your entire small bowel, and lifelong dependence upon TPN or consideration for a small bowel transplant. So it is a life-changing diagnostic failure for infants and their families. And why are there barriers to timely diagnosis? Well, there's a variable clinical presentation. And when the clinical presentation is clear, it's frequently already now at advanced stages of intestinal ischemia. Access to upper GI may be limited. We get patients transferred in because they don't actually have access to an upper GI at all. Or there may not be 24/7 staffing of a technologist or a radiologist, so that can then lead to delays, for example. And so ultrasonography may be more accessible. You may have an ultrasonographer there 24/7, but the technique is operator dependent. You do really then require 24/7 trained technologist, radiologist, and again, it's best for volvulus. So as a neonatologist, if you're malrotated, you are at risk for volvulus. I would rather find malrotation before there is volvulus instead of being in a position where we already have volvulus, particularly because volvulus can be intermittent. And so then we also then want to avoid diagnostic error, but again, also strive for diagnostic excellence, because clinical medicine is ambiguous, and that is just the reality of how we practice. And so Dr. Graber merely thought through the types of diagnostic errors. And so no fault is basically the disease is silent, it presents atypically or mimics one or more other common diseases. And so is it preventable? It may decline, but it's never going to be fully eradicated. Systematic contributions to diagnostic error is really, again, these are imperfections in the system. You can probably substantially reduce them, but essentially never eradicate. And same thing with cognitive contributions, where we have a delayed or misdiagnosis, and again, potentially substantially reduce, but never eradicate. And if we think through the process of diagnosis as we evolve in our careers, we do get better and more reliable and accurate, particularly for the common diagnoses, and costs a lot less cost, time, and effort as we move from beginning to expert. But our reliability and accuracy is never going to be 100% if we just rely again on our reasoning alone. And so again, that's where this concept of missed opportunities in diagnostic excellence is not just thinking about really error, but where are the opportunities where perhaps we had delays and maybe there wasn't even harm. So missed opportunities, which could be system or cognitive, may or may not contribute to harm, but we want to look at all those missed opportunities to think through how we can prevent them. How can we prevent diagnostic harm? There are times when you can have harm without a clear evidence of a missed opportunity. When I was a resident, we had he was, I think, 7 or 8 years old, had come in for consideration for small bowel transplant after a delayed diagnosis of volvulus, because he had presented to the ED with days of vomiting that had turned bilious, severe metabolic acidosis, severe hyperglycemia, and so was diagnosed with DKA. Made total sense. He was so hyperglycemic and acidotic. It's like, okay, you probably have DKA. And eventually they actually moved on. Something had triggered them to get imaging. That was a CT scan, and he had volvulus and was being transferred for evaluation for small bowel transplant. So in that, I would say I'm not sure that there was really a missed opportunity. He came in already in advanced stages. He had the classic signs of DKA in an age range outside what would be typical for volvulus, and they did make the diagnosis, albeit not necessarily at a point where there was recovery for the bowel, but probably at presentation that was already done. And so Measure DX is actually available from AHRQ that really provides a resource to thinking through and analyzing and learning from diagnostic safety events. And so we need to be able to gather the data for actually misses and good catches, analyze them, think about how we can change practice, and then create or sustain an initiative to learn so that can be ongoing over time. And so that's in part what the Safer Diagnosis Framework really seeks to do. And again, here is a picture of that diagnostic process. And then any breakdowns of that can lead to diagnostic errors. But really, when it comes to safer diagnosis, that's when we can not only measure them, but also learn from them, calibrate from them, and then think through, again, better measurement tools, definitions, feedback, and have ongoing goals to improve diagnostic safety. And so what is it? What it is it measures missed opportunities in diagnosis involving 5 components of the diagnostic process. The provider-patient encounter, which includes history, physical exam, ordering tests and referrals, performance and interpretation of diagnostic tests, follow-up and tracking of diagnostic information over time, subspecialty and referral-specific factors, and then patient-related factors. And what it is here, hopefully you can read it to some degree, is really an instrument. And what you do is you walk through these 13 items and you grade them on a scale of 1 to 7, 1 from strongly disagree to 7 to strongly agree. And this is just a very simple Likert scale, depending on how you pronounce that. But in many cases, so for example, if you think through the pediatric milestones, they give you anchors of descriptions of those different points. In this, it really is simply a 1 to 7. As you're reading this and you're reflecting on a case, what do you disagree or strongly agree? What was there something here? So for example, alarm systems or red flags were not acted upon. In this case, do you disagree or agree on that element? Diagnostic data was documented, was misinterpreted, there was missed follow-up, these elements that I've worked through with you. And you put a score down, but what you don't do is add them all up and come to a number. What you then reflect on is that last question in number 13 was, in conclusion, based off of all of the above review, was there a missed opportunity to make a correct and timely diagnosis? And that's what we call a mode, a missed opportunity, not a failure, not an error, but truly just a missed opportunity. Additional steps does ask if the care episode involved a management error. This also isn't always straightforward. I've debated this back and forth with colleagues as we review cases. Did it require care escalation? Was there a patient on the floor that ended up in the ICU? Did the patient factor of initially refusing admission or additional evaluation, right? Did that influence the diagnostic process? And then give a brief description on any thoughts and observations. And so if we take the case example that I gave of malrotation with volvulus, I don't know why that's there, but oh, there we go. Okay, so I just took this case and I reviewed it in SAFER-DX, and where I felt that that scored higher again was this alarm symptoms or the red flags. This concept of bilious emesis is different than a bilious residual in a preterm infant. The clinical information should have prompted additional diagnostic evaluation. If you are thinking about malrotation with volvulus, if you're getting an ultrasound, don't necessarily then be reassured by a negative finding. Was the diagnostic reasoning appropriate? I mean, really, there was anchoring on this is a patient who's a preemie who's just having slow motility. And the clinical presentation or initial or subsequent was mostly typical of the final diagnosis. That's true. Infants with malrotation volvulus present with bilious emesis, right? That's an emergency in a pediatric patient. And so then in conclusion, based off of the above, there was a missed opportunity to make a correct and timely diagnosis. In my personal experience, some of the challenges, and I've actually walked our division through cases, for example, of sepsis, and we've worked through as a division to score them together. And where some debate came up, which was the clinical information should have prompted additional diagnostic evaluation. And how do you score that? Which, when it was obtained, like let's say the team had done an upper GI that identified it, but there was already advanced intestinal ischemia, so they got it, but it wasn't timely. Again, that's okay, because this framework is just allowing you to construct whether or not you believe there was a missed opportunity, not necessarily a absolute yes or no, whether or not there's a diagnostic error. And always I acknowledge when I'm talking to providers about cases is that I'm doing this with hindsight. So I have all of the information as it had evolved over the course of this case, which you don't have when you're in it in the moment of the diagnostic process. And so really then what missed opportunities allow us to do is to think through system redesign. If you do quality improvement, you'll hear this quote a lot. It's attributed to many different really smart people in quality improvement, but that every system is perfectly designed to get the result it gets. And so if you want a different result, you have to actually redesign your system. And so not to bash on cognitive biases, because I think thinking through what a cognitive bias is actually important, but it doesn't help to explain the why, the what happened and how can I improve. And so that's where when I struggled in education, helping learners think through is like, well, I can tell you what the bias was, but like, how do I then help you think through to do it differently the next time? And that's where the DEAR taxonomy then actually does help guide us. So Safer DX, was there a missed opportunity? And then the DEAR taxonomy is like, okay, well then what happened? What is that there, if you think through an apparent or root cause analysis, you want to say why, until you don't have any more whys left. Well, this sort of points us to those steps. So for the case, I felt like there was a suboptimal weighing of a piece of the history data of this bilious emesis, but really, it came down to testing and performing what would be the gold standard in the vast majority of institutions, which is an upper GI. And so there was a delay in ordering tests and not necessarily performing them, but suboptimal test sequencing as well, for example. As well as too much weight given to a lower probability or priority diagnosis. This was a case where it was, okay, it's just a preemie. I need to step back and leave the preemie alone. I'm just letting them do preemie things, as opposed to, am I really going to take a 28-weeker down for an upper GI and put them through that? Well, in some cases, yes, but that is always then the debate, particularly, of course, because it always occurs at 2 o'clock in the morning. And then you're having resources to send a baby down for a more invasive test. And so then if we take that case and then think through opportunities for process improvements, you could develop a standardized approach for management of bilious emesis in the newborn, which could include sequencing of ordering imaging. And then you could also consider standardizing within the radiology service the order of diagnostic testing, and/or even better, have an order set somehow embedded in your electronic medical record to standardize the sequencing. So if someone is ordering we have an ultrasound for volvulus, then you also flag them, well, don't you also want to order an upper GI? And so what we do at our institution is patients can get them actually at the same time. And so if you're doing an ultrasound as you're waiting for a tech to be available and identifies volvulus, well, then you don't need the upper GI. But if your ultrasound is negative, you move on then to the upper GI, or the ultrasound tech isn't available, upper GI is available, just get the upper GI. And as we think through actions to improve safety, the temptation is always to send an email, put up a sign, we want to do better, and that's all fine and good, but it's not actually going to change your system. And so that's where, again, thinking through the DEAR taxonomy of where systemically can I take this moment and adjust my system. And so the DEAR taxonomy group did give some recommendations around improving diagnostic safety, which focuses a lot on building a learning organization where feedback following diagnostic errors is routine and is part of embedded into your daily, everyday life of improving patient care. They did conceptualize some safety nets to mitigate harm, which included follow-up of abnormal test results. So in Rory's case, having a way to say, all right, this kid went home from the ER with 54% bands. What is our process to follow up on that and then find them and bring them back if we think that's necessary? More standardized and reliable protocols for reading x-rays and laboratory tests. Pathology specimens is actually, particularly in the adult world, a contribution of this. And they acknowledge the contribution also of learners, as well as the after hours element of diagnostic process, and then to better delineate what are some red flags and don't miss diagnoses and situations, but also then how can we avoid them. So there are a few institutions that are actually using triggers within the electronic health record to identify cases. And so this was a study out of a PICU where they utilized their electronic health record to retrospectively identify cases from a 6-month period. And they had pre-specified 4 high-risk cohorts: patients who had died, as well as with an autopsy, patients who were seen outpatient within 2 weeks of PICU admission, patients who had an unexpected PICU admit and needed vasoactive meds within 24 hours, so a rapid response from the floor, for example, or they had an unexpected PICU admission from the floor without a subsequent decompensation. And they found 214 patients over the course of 6 months and identified 26 diagnostic errors using the Safer DX instrument. which had a high inter-rater reliability with a kappa of 0.72. And there's the distribution of misdiagnoses there, many of which are infectious. And that's because sepsis is so hard. And particularly in today's healthcare environment, in the pediatric patients that are admitted in hospitals, they are incredibly complex and their physiology is frequently just deranged at baseline. And so then sepsis it rears its ugly head, unfortunately, sometimes at very advanced stages before it's clear. Neurologic findings such as stroke was on there, gastrointestinal, vascular was cardiomyopathies, pulmonary hypertension, and the other was a hemolytic anemia. So New York State did pass Rory's regulations in 2013, and what they did was they mandated the use of protocols for sepsis recognition and treatment. Which then also required reporting of this adherence and outcomes to the state registry. And so there's been a few publications of what happened following these regulations, an adult publication in JAMA, and this was a pediatric publication which used an administrative data set of basically ICD-9 codes for over 9,000 patients, and they compared mortality in New York State to 4 states that didn't have sepsis regulations. And in unadjusted analyses, there was no significant difference between the two groups. When they excluded metropolitan hospitals that had already participated early in the Stop Sepsis campaign, they did see some signals, and as well as when they looked at some specific subgroups, for example, of previously healthy children or children that were not admitted through the ED, who were already in the hospital, they saw some signals for improvement. But what you can also see here, and this is why with quality improvement we do series over time, is you can actually see that the gray bar is when Rory's regulations were passed, and actually New York State was getting worse, and then it got better again. So why was it what was happening that was getting worse? And this is where, in this concept again of time series and looking over time, but also annotating what you think is going on is helpful, because there were within many of the academic centers work on sepsis already going on. And so at a global institutional healthcare organization level, NAM is again saying this diagnostic error and excellence is the next frontier for patient safety. And so within their publication gave recommendations on how to achieve that, which really includes building a diagnostic safety program and thinking through actually how are you going to measure it. Do you actually already have data collected by your organization? Are you soliciting reports from staff? Are there patient-reported data that you can leverage? As well as, is there ways to mine your electronic health record to find cases? But these are all cases after the fact. We do have a Center for Diagnostic Excellence at CHOP. And so this lives within our Center for Healthcare Quality, and it is run by our medical director of patient safety, Megan Galligan, who is one of our hospitalists. There is a program manager that helps intake and then review of cases and assigning cases. I am one, for example, of the departmental patient safety officers for the Division of Neonatology. So I'm on that kind of cross line there. And so I'm assigned cases for review. I solicit cases for review. And we do this at our divisional level, but also at the hospital safety level. When we have cases that we're reviewing, we'll review this process. And so this is how we apply it. There's a red cap that there either is an email link that I go to, or there's a QR code, and anyone can put in a case. And you really just provide a brief clinical background and then say who should review it. A number of us have been trained. It took about an hour to do a training session. And so those of us that are trained are routed the case to review. We have at least 2 reviewers per case. And then if we identify within our review a missed opportunity, it then triggers us to then map it to the DIR. If we don't identify a missed opportunity, then we're done and that case goes into the system. If there are discordant findings, then we re-review together with the reviewers. You get an email and say, you had discordant findings, please develop a consensus review. And we find the time to then meet together, and then we submit another review that's consensus. And then also give recommendations. So should this case just be reviewed locally within the Center for Diagnostic Excellence? Should we actually do this case as an M&M within a local division? Or does the hospital safety team need to be involved in this case because of the concerns? And so, as with many things, you can start small. We've obviously got a great infrastructure here that is built over time. But these can get incorporated into M&M conference, which I have started to do with our group. I use them for apparent cause analyses. I've actually done them for a proactive ACA where there wasn't really a safety event, but we recognized that we were really vulnerable for this happening again. And so we actually utilized that to adjust a scoring system that we do for neurologic assessment in the NICU. And you really can't discuss diagnostic errors or excellence without thinking through the concept of psychological safety. Amy Edmondson is one of the leaders in the concept of, or the leader probably, in psychological safety. And the Fearless Organization is a really great book if you have the opportunity to read it. Also not long, also easy to read. And she's a phenomenal speaker. So if you ever have the opportunity to hear her speak, she's amazing. And, you know, she will say that it's not about being nice. It's about giving candid feedback, openly admitting mistakes and learning from each other. And this just isn't in the context of diagnostic error. This is in the context of any error. And it's really feeling the ability to speak up without concerns for retribution is another one. She came and gave a talk at Penn. And so I took this picture. And she was actually describing in this slide a discussion that she was having with an anesthesiologist, where she was saying, well, like, you know, how does it feel when someone points out my error? And they acknowledge it's actually really good. It's like, really? It feels good? And it's like, well, it didn't always feel that way. Because after doing it for a while, you realize that if someone has spoken up and raised a concern, it means they're vigilant, they feel comfortable speaking up. And that ultimately it means that patients will be getting safer care. And so it is hard, I will say, to review cases, particularly in a larger group, and think through, you know, you have individuals that are then feeling terrible that I didn't have diagnostic excellence, or I had an error in this case. How do you support those individuals? And so, as I always say, number one, we never hold individuals accountable until we have a perfect system, which we don't have, but also any one of us yesterday and tomorrow, because all of us are at risk for missing cases or for having clear diagnostic errors. And so then how can we come together to improve our system? And we don't know about them until we hear about the cases and can learn from them. And so I'm happy to take any questions. The biggest one I sort of briefly mentioned was a patient that we recognized that we were at risk for. So if we have a patient who has undergone a period of pharmacologic paralysis, they can be paralyzed with vecuronium for a few weeks, and they come out of it and you're like, oh, they're just not moving because they've been paralyzed for 2 weeks. But then it's like 5 or 6 or 7 days later, and it's like, well, hold on a second. Did we actually potentially miss something here? And so there is, and we had not participated in this assessment of neurologic function that the PICU had adopted, because most of the neurologic abnormalities we see are HIE, but we actually ultimately did adopt this standardized form, which is just you assess this patient over time, and it's meant to raise the red flag of something is different. That's probably the most tangible that we've done recently. And I'll acknowledge that it's taken many months to get it into Epic, as anything does when you're changing the EHR. But it isn't always easy. And the hard ones are sepsis recognition, particularly when we have cases where, it's a few hours and well, how many of those hours mattered? Particularly in a patient who's already so sick. Depending on the case we do, usually not just because of the way our M&Ms are structured. Certainly if there was a case where there was a big multidisciplinary influence, we'll do a multidisciplinary M&M. The safety office is comprised of patient safety process managers, many of whom are nurses. And then our safety quality specialists or bedside nurses, and they will do a lot of the discussions with the bedside. And so if relevant, we pull them in.
How do you engage the house staff with M&Ms? Because traditionally here, I mean, we have some M&Ms that the house staff aren't, a lot of times they're at a separate conference at the same time.
Yeah.
Is there anybody that you know of that is really doing a good job of, and how are they doing it, getting, including house staff in the M&M? Because it makes sense that we train residents in that area.
So I am less involved with graduate medical education at CHOP than I was at Sinai. Well, we had resident run M&Ms every month, and we will invite residents to their divisional M&Ms. So it's like, and there's many divisions. But if there's cases where a resident was involved, then they certainly get invited. They do more of our clinical time at our hospital, University of Pennsylvania. Not everyone rotates in the CHOP NICU, for example, but they have a separate M&M process that the residents attend when they're on rotation. But I acknowledge that it is particularly for trainees hard when you're pulled in so many directions. But I enjoyed having the resident run M&M when I did it at Sinai. I'm not sure actually how CHOP does it for residents. But the fellows run our divisional M&Ms, and I and another faculty mentor them, which is, I think it's harder, but it's a good learning experience.
We have a lot of fellow run M&Ms.
Yeah.
And I've got 8:30, and I've been promised not to keep the residents beyond 8:30, so that's all.
Yeah.
Oh, residents, okay, if you take a picture of that QR code, not only can you rate the session, but also you can give any comments to Dr. Gibbs, but also any future suggestions you have for M&Ms, topics you'd like to have. I just put that in just one box, you can type in anything you want. Thank you very much.